Hi, the topic that I've selected for my argumentative video assignment is Where do we draw the line? Providing guidelines for genetic engineering. Before we begin, we should establish what genetic engineering qualifies as, and these can essentially be described under the three following processes. The first is genetic testing, which encompasses prenatal, newborn, and developmental testing. Essentially, these processes screen for conditions or diseases that range from lethal and life-threatening to ones entirely cosmetic in nature. The next is genetic therapies, and these therapies are categorized under somatic and germline. Somatic therapies are entirely modifications made to somatic cells and cannot be passed on to future generations, as opposed to germline therapies, which can be passed to further offspring and other children down the line. Genetic enhancements are the third, and they essentially capture physiological improvements in the absence of disease. So performance benefits to athletes would be an example, basically beyond the capabilities that nature is able to provide. So now we've arrived at the moral issues that I've selected for analysis, and this kind of captures those three procedures that I mentioned previously. So to begin, for genetic screening, what are we going to allow patients to test for, since this kind of captures those conditions that are life-threatening and also just those that are cosmetic in nature. So where are we going to establish the lines of what patients can test for? As for genetic therapies, which therapies can be reasonably used to treat disorders? And if they can be used to treat disorders, how do they differ in guidelines to those established for our genetic screenings? And finally, for genetic enhancement, the question is simply, should these even be allowed? And how are we going to navigate a world where we treat physiologically superior humans compared to those who have disabilities or simply those who are just naturally born? So before we begin our arguments, I think it's important for us to establish a moral basis for us to base our claims on. And I think the text offers a strong foundation to establish our position on genetic engineering. Vaughan in particular provides a case study that actually serves as an ethical stepping stone for my conclusions. So he presents this situation where one of three siblings has been diagnosed with a inherited metabolic disorder after screening. And her name is Maria, and she's suffering from these severe symptoms associated with the disease. But actually, she declines to disclose this diagnosis with any of her family, including her siblings who actually have a 1 in 4 chance of having it. So this disease can actually be effectively managed if treatment begins before the onset of symptoms, but she still refrains from disclosing this to her family. And Vaughan juggles between the multiple perspectives that scholars have on this topic. And some say that her privacy is sacred, given that the principles of patient autonomy say that her wishes should be fulfilled in this regard. But some also say that physicians have a higher moral obligation to prevent additional suffering to others. So my perspective on the matter is that Maria actually is inflicting direct suffering on her siblings by not disclosing this information and allowing the potential for the disease to linger on untreated, simply by not informing them of her discovery. As a result, I think Maria's siblings actually all become patients in this regard, as they are directly impacted by novel information. So it's not a violation of patient autonomy, and especially in this case when they should be informed of their potential diagnosis. So by establishing patient autonomy as a fluid concept that encompasses these situations that are captured by genetic engineering, the physicians also have a moral obligation to reduce harm, and we have now established these kind of foundations that we can use to create our guidelines now. So as for genetic testing, our established principles on patient autonomy basically say that we should provide access to these tools to test for potentially life-threatening conditions. And we also have a moral obligation to inform parents of the results of these tests, including those that qualify as life-threatening or induce physiological pain. But I do believe that screening should be limited to these disorders and exclude any preferential or cosmetic traits. And for example, Vaughan provides another case study in the text where parents are given permission to actually select an embryo without a cosmetic condition in the United Kingdom. And their physicians justify these procedures on the basis that their appearance could lead to bullying and cause a family emotional distress. But while I think these could be reasonable, their reasons are entirely speculative and have very little basis on physiological health. And these genetic conditions are based on societal norms, and these biases also invariably will lead to more pervasive genetic discrimination and potentially another degree of classism, depending on if these accessibilities or if these technologies are not very accessible. So if we kind of just take a more lax stance on screening, physicians will find screening counterproductive as a counterproductive method in general for curtailing discrimination. And screening for cosmetic conditions shifts the question from whether a child will be born or if they'll live a long and reasonably pain-free life to kind of what type of child parents want. So intrinsically, children cannot consent to these or even generations of offspring down the line. Patient autonomy then comes into question as that right also encompasses the child and future generations. So my stance on genetic therapy is pretty similar to my opinion on genetic screening, but it's just slightly different. So genetic therapies should be offered to those who are experiencing symptoms of conditions that are being screened for, but also consenting individuals should be allowed to seek therapy for conditions that are considered a hindrance to daily life, and this should include cosmetic modifications on the basis of expression. So these situations actually satisfy the conditions that prenatal or newborn testing did not, since patient autonomy and informed consent can now be provided. So physicians also have a moral obligation to provide these somatic therapies that are not germline in nature, that only impact the lives of consenting patients and can't be passed on to offspring. An analogous procedure would be kind of like plastic surgery, where these modifications have no impact on future generations. So genetic discrimination and classism could be enforced if these procedures are allowed to continue. However, these indirect consequences should probably take less priority than the rights of patients who are seeking these procedures. So physicians have to kind of walk this fine line of ensuring that these kind of maybe potentially troublesome procedures should be considered while avoiding the adoption of this paternalist framework if there's oversteps involved. So we kind of have to consider these differences. However, once we get into the territories of genetic enhancement, these conditions kind of break down. So my stance on genetic enhancement is much more staunch, and I think that enhancements are kind of within the realm of providing objective benefits. Whether they are physical, mental, or physiological, they're not really possible within a natural setting. So I think these traits essentially are deemed universally superior, and they don't enhance human or personal expression in a manner that gene therapies would. But they're kind of just used to surpass the capabilities of naturally born humans and kind of destroy any existence of meritocracy. So now we kind of have to enter the discussion of eugenics, since these enhancements are essentially just considered superior. So physicians and lawmakers now have a moral obligation to prevent these modifications from being made so they can avoid excessive tampering of the genetic pool and also kind of the introduction of traits beyond the capabilities of nature. And in general, there's just this nervousness associated with turning reproduction or genetic engineering into this highly commercial enterprise where people get to kind of pick their type of children. So this kind of just creates a situation where people are also less accepting of people with disabilities or conditions, or just those who are naturally born. So I think it puts us in a very precarious spot. So in discussions with my classmates, they've actually brought up a pretty reasonable objection, stating that the right to abortion kind of does not fall in line with bans on germline genetic enhancement. But I fundamentally disagree, as these situations are pretty different. In the case of abortion, the mother's life and autonomy are being impacted, so they are the patient in question. The potential for life also should not qualify as a patient, and it's ultimately the mother's choice for a life to begin or not. And also, if you think that a fetus or this body of cells is fundamentally alive, then a moral right to life does not entail that a woman is also obligated to sacrifice her body in order for this clump of cells to gestate for 9 months. And when considering genetic modification, it's not only a question of the mother's life, but now a child will be born, and their genetic makeup will be impacted along with their future offspring. So it would be a violation of patient autonomy, as this child who is now being born has their right to physical and emotional freedom of determination being stripped from them. And also, if they are stripped of their right to the natural physiological traits, then informed consent cannot occur. And famously, in her defense of abortion, Judith Thompson stated that a newly fertilized ovum, which is a newly implanted clump of cells, is no more a person than an acorn is to an oak tree. And lastly, these are my citations, and this concludes my presentation on genetic engineering, and thank you for listening.